Thanks everyone for coming, and hopefully we don't impede on your lunch too much here. Our talk today is going to be focused on direct anterior hip replacement. These are some of my credentials she went through very quickly there, and she hit it all perfectly. As she said, my special interests and my fellowship training is in joint replacement, both primary replacement as well as revisions. And then also over the last couple of years, outpatient joint replacement, and we'll address some of that at the end and how anterior hip replacement has allowed me to do more and more outpatient type surgery where you can recover at home. Our objectives today, we're going to talk about what a hip replacement is, why I use the anterior approach, namely the advantages there, the risks of surgery, post-surgical expectations, and how we determine whether or not outpatient or same-day surgery might be appropriate for a patient. So most people who have or need a hip replacement or are suffering from hip pain are going to have osteoarthritis. On the right side here, we can see a normal hip with a nice round ball and socket. You can see there's a good space in between the bones. That's where our cartilage lives. Cartilage lubricate or is a cushioning on the end of the bone that is very smooth. And when it's there, it's slicker than ice on ice. However, on the right side of the screen, we're going to see a very arthritic hip. We see these black circles. These are cysts that develop as the bones begin to rub up against each other. They irritate the bone and cause cysts. We see this white bone here. This is called sclerosis. And then we can see that the bones are touching each other. So that space between the bones is gone. And particularly in this patient, you can see where their hip joint has actually shortened. And so some people will actually experience one leg shorter than the other in this situation. So osteoarthritis, more than 43 million people suffer in the United States, suffer from some form of arthritis. Nearly 21 million of those are osteoarthritis or degenerative changes where that cartilage cushioning has worn off the end of the bone. And estimates for 2020 were somewhere around 60 million people were expected to have osteoarthritis. When we do get to the point where people need a hip replacement, usually our goals at that point are going to be to relieve pain and restore motion and function. As people become more and more painful, they're unable to do the things they enjoy. And more importantly, they lose the ability to do the things that they need to do on a daily basis. Particularly with hip replacement, patients will complain of inability to reach forward and tie their shoes, stiffness getting in and out of bed, difficulty putting their pants on, and these are things that drive patients to seek out surgical intervention for hip pain. Well, I had a little video there for hip replacement, but it doesn't seem like it's going to work on this media. Basically, it was an illustration of what we're going to do for hip replacement. During hip replacement, we're going to resurface the socket side using a metal socket with a plastic liner placed in there. And on the thigh bone side, we're going to remove that round misshapen head, and we're going to put a little metal wedge to stabilize the head with a ceramic head to articulate now with your new plastic socket. For the direct anterior approach, which is what I use for hip replacement, a lot of patients will ask, is it new? It's neither new nor experimental. It's actually been around since the 1970s when we started doing hip replacement. It's a little bit more of a challenging approach, so it does take some training for the surgeon. But because of its advantages, it's really gained traction, and surgeons who are training in with more modern techniques are choosing more and more to use the anterior approach. Going from the front of the hip gives me a direct path to the hip, so no muscles need to be cut, whereas the traditional posterior approach or the approach from the side of the hip often require taking down muscles and tendons and trying to repair them for stability or strength of the hip. The scientific studies do show us that patients who have the anterior approach can recover faster. Some of the studies show that the patients have less pain. But more importantly, it shows that we don't have to give you as many restrictions after surgery. The patient or in this case, if you're the patient, you're going to lay on your back, just like I would examine you during surgery. I can have full control of your leg. I can check how your heels line up. And this helps us with accuracy during surgery. The incision is often smaller, although many really experienced posterior hip surgeons have very small incisions. And again, no hip precautions, meaning you don't have to watch how far you bend your hip after surgery. You can pretty safely bend your hip. I get to use live x-ray during surgery, which is a little more difficult if you're laying on your side, like traditional approaches will use. This allows me to really match the shape of your hip up with your healthy hip or what your hip looked like before surgery. By matching your shape up, we can really more accurately match up the mechanics of your hip and give you a more natural feeling hip. It's also less likely to dislocate because we can really see the position of the implants and we know they're in good position before we leave the operating room. And again, when you're laying on your back, just like you might be in the office, we can really check that leg for making sure that your legs are of equal length. Just like any surgery, there are risks with hip replacement. One of the risks that we worry about is infection. Infection rates are low at our local institutions, but they're never zero because bacteria is all over our skin. It's in the environment when we're operating. And so we do take every precaution necessary to prevent infections, but they do occur at times. Blood loss and blood transfusions are very low, more likely to happen with a hip replacement than a knee replacement because we can't use a tourniquet, but again, less than 1% in our local institutions. The disadvantage of getting a blood transfusion is that it does sometimes cause reactions, as well as put you at a little bit higher risk for obtaining an infection after surgery. Blood clots, including blood clots in your legs or in your lungs, can occur after surgery. We will put you on a blood thinner. Most of my patients take a baby aspirin twice a day. This has been found to be just as effective at decreasing fatal pulmonary embolus as what and DVTs as a stronger blood thinner with less risk of having bleeding after surgery that causes the need to have a reoperation. Some patients that are high risk, though, we will use a stronger blood thinner in order to prevent those life-threatening blood clots. Dislocations can occur after any surgery, but again, they're less likely after an anterior hip replacement. Again, with the use of x-rays during surgery and the positioning of the patient on their back, we're able to decrease the risk of leg length discrepancies, but those can still occur. Fractures can occur during surgery. As we're preparing the bone for the new implants, they have to fit in there very tightly. And occasionally a fracture will occur as we have to make sure that if we put it in there too loose, sometimes it can not grow in appropriately, or it can what's called subside, and then your leg will end up shorter. Nerves and arteries are at risk during any surgery. We're careful to protect them, but these things can occur, which can cause weakness after surgery or loss of sensation. And then there's the general risk of anesthesia. Stress on your heart and lungs, and it's a big surgery. So we will make sure that your primary care doctor and any specialists that you see that need to sign off on surgery are okay with us proceeding with surgery. So some things to expect after surgery. Most surgeries, at this point, about 60% of my surgeries stayed overnight in the hospital last year for joint replacements. And if you're going to stay in the hospital, typically, based on Medicare requirements, you're going to stay one night. And if everything goes well, you'll go home the next day. And again, this isn't dictated by the hospital. It's dictated by your insurance and Medicare. If you do have a medical problem that requires a longer stay in the hospital, we will admit you to the hospital and you'll stay so that we can get that cleared up. You'll get physical therapy on the day of surgery. And this will have you walk around on the floor. You'll be on a pain regimen that's aimed at minimizing the use of addictive pain medications. So things like Tylenol and anti-inflammatories, but we still will use some narcotics where it's necessary. Physical therapy after surgery, the ideal place to do physical therapy after you've left the hospital is in an outpatient setting where there's equipment for you to gain strength and recover faster. Most patients will graduate quickly from a walker or a cane. In fact, the majority of my patients come in at their 6-week visit and have no walker or cane or are completed or nearly completed with their physical therapy. We're going to wean you from pain medications as your pain resolves, trying to, again, eliminate the use of any of that addictive or habit-forming medications that are used early on. One of the things that some people will notice, actually a lot of people will notice, is some anterior stiffness, especially in those first couple months after surgery. When you get out of a chair, it'll feel kind of like that scar tissue in the front of your hip kind of bunches up and you got to get it stretched out. That tends to resolve over those first several months to a year. Some people will experience numbness where the scar is at, and this is just related to a sensory nerve that goes down the front and side part of our thigh that's very close to where we operate. Most people, this will resolve or become small and unnoticeable with time. So just a quick note on how this has allowed me to do more outpatient or same-day surgery, a little bit on the evolution of that. In January of 2018, total knee replacement was removed from the inpatient only, meaning that when you go to the hospital and you stay the night, it's no longer an inpatient admission, but now an observation stay. In January of 2020, total hip replacement was removed from that same list. And in November of 2020, Medicare announced its intentions to do this for nearly all of the 300 plus musculoskeletal related procedures that were on that list still. And this also includes total shoulder replacement. This means that these procedures will require appropriate medical reasoning for stays longer than one night in the hospital, as we addressed earlier. In the United States in 2020, we were estimated to do about 1.2 million. The estimation was that about 10% of these would be done in a same-day surgery setting. The experience we had last year with COVID-19 and patients really being hesitant to be in the hospital for any long period of time really accelerated that. In fact, last year in my practice alone for total joint replacements, about 40% of my patients went home the same day of their surgery. It's a normal joint replacement. We just go through a little bit accelerated process. And from a medical standpoint, we want to make sure that only patients who are medically able to go home do that. We don't want to do this for patients who have heart disease or a lung disease or kidney disease that will require close monitoring after a set of anesthesia. This process begins in the office. You'll meet with my physician assistant. He'll do preoperative education. He's also going to do your postoperative education at your pre-op visit. So you want to bring someone along if this is what you're interested in, so that you can get all that education. There's going to be a lot of information. The second set of ears is very helpful. We also give you all your medications ahead of time. Your PAT visit will go over some of your postoperative therapy exercises and such that will help you be prepared for when you go home. On the day of surgery, you'll come in like any other surgery. You'll have your registration. The nursing staff will prepare you. The biggest difference is that after surgery, we're going to walk you in the recovery room instead of sending you up to the floor. Once your anesthesia is settled down and the spinal has gone off, once your stomach settles and you're able to, physical therapy or the nursing staff will walk you, and then you'll be eventually discharged to home. This means you might spend 4 to 6, maybe 8 hours at the hospital that day. The advantage of this, obviously, are that you can recover at home. It's been shown that the risk of complications, probably most likely related to our patient selection, risk of complications is lower for patients who are able to go home. If we are able to, prevent you from being around other sick patients when you're actually a healthy patient, we can sometimes prevent some of these other infections. And again, as we've seen over the last year, being out or any admission to the hospital is an exposure to potential patients who have other disease processes like COVID-19 or infections that, being a joint replacement patient who is otherwise healthy, you really don't want to be exposed to unless you need to be. So that's my brief talk on hip replacement. These are my credentials. Visit us at our website, worcesterortho.com. Again, I operate primarily through the Altman Health System at Altman Orville Hospital. We see patients at the Altman Orville campus. So happy to see any of you